Good morning, everyone. I hope we're doing well this morning. I am Dr. Nidisha, Senior Resident in Department of Neurosurgery at AIIMS New Delhi, and I'll take you through the program today. I welcome you all to the 7th Annual AIIMS Neurotrauma Conference, organized under the aegis of Indian Society for Trauma and Acute Care. We will now begin our program, and I request Professor Sharat Chandra, Professor and Head of Department, Acting Head of Department of Neurosurgery, to open the program.
So good morning, everybody. It's a pleasure to be here, and we start this very important conference, and credit must be given to people who have started it, especially Professor Deepak Gupta. And as of today, this has become a very important learning platform for a lot of neurosurgeons as well as residents. And the program this time has been arranged very well. It's been made in a way so that every aspect of it is very interesting, and I will strongly urge all the residents as well as the delegates to fully participate in this and make it a grand success, and also keep on coming to this program year after year. So thank you very much, and we wish to have a wonderful program and have your complete wholehearted participation for the next couple of days. Thank you.
Thank you, sir, for opening the conference. We now begin with our session 1 on guidelines in special scenarios. I request Professor A.K. Mahapatra, Dr. V. Sundar, and Professor Ashish Suri to kindly chair the session. Our first talk will be by Dr. Manjari Tripathi on subclinical and overt seizures in traumatic brain injury, when to stop, and drug selection issues. Good morning, and at the outset, I'd like to thank the chairpersons as well as the early birds in the morning here, as well as Professor Deepak Gupta for asking me to be the opening batswoman. And of course, my talk is going to be on the topic which I deal with, which is epilepsy, but tribute to the Trauma Center, which has made possible better care for trauma patients in our country, particularly in North India. And we know accidents aren't anticipated. They happen within few microseconds, and they come like a bolt out of the blue. So really, it is something which we are not prepared for, and least to say that the sequelae which patients are left with, one of which is seizures, even more so, we are not prepared for. This entity of trauma followed by seizures makes epilepsy a completely preventable disease, particularly post-traumatic epilepsy, and somebody who's had a head injury and then has epilepsy has a double whammy. So it is to deal with two circumstances which, of which seizures don't really carry a good picture in our population because of the associated stigma. So we know when there's an impact, there can be an immediate seizure, and this immediate seizure usually occurs as soon as there's the injury, and immediate seizures do not significantly increase the risk of later seizures. This has been shown by elegant studies, whereas early seizures are those which occur within the first 1 week following the injury. Some studies have taken longer periods, like a month following the injury. And of course, these seizures are the ones which can be troublesome, particularly if the patient is in your ICU. Many of these patients can be in status. So early seizures occur in about 5 to 25% of patients, usually within the first 24 hours. And the risk factors are if there's a diffuse cerebral edema, if there's some metal fragment retention, if there is a fracture, whether it's a linear fracture or a depressed fracture, and if there are residual focal neurological deficits in your patient who's in the ICU. Now, late seizures, the risk factors in multivariate analysis, the happening of early seizures within the first 1 week is not really, does not really confer a huge risk for late seizures, or in other words, epilepsy or symptomatic seizures due to a head injury. Now, if you look at the percentage of increase following a head injury, and I don't need to tell neurosurgeons what a mild head injury is and what a moderate head injury is, but if you look at a severe head injury, the 5-year cumulative probability of the patient ending up with epilepsy is as high as 10%. And the relative risk is 17 times higher. So you really need to follow up your severe head injury patients. For a moderate head injury, it's about 3 times higher. Now, we know the definition of head injury, and in this study by Enegers, which is the most widely quoted study, published in NEJM, where we had mild to moderate, and the moderate was associated with a skull fracture. The definition of severe in her study was wherever there was amnesia more than 24 hours, and the GCS was 3 to 8. The loss of consciousness was definitely more than 6 hours, and it was associated with a brain contusion or hemorrhage. So let's look at what happened to her patients. Now, when there was a severe head injury, about half of them are going to have seizures within the first 1 year. So really you need to be vigilant and keep asking them whether they are episodes of LOC. And the risk of first seizure remained elevated for the next 10 years. Whereas after the mild head injury, the risk of seizures subsided after 4 years. So for mild head injury or moderate head injury, you can take a 4 to 5 year cutoff. If you look at the factors which were associated in this study, if there was a brain contusion, look at the rate ratio, it was almost 12. And that's on multivariate. And subdural hematoma, so if there's a contusion with a subdural, it's almost 12. If there's a subdural hematoma, it's halved, that is 6. If there's only brain contusion, it's 5. And if there's a linear depressed fracture, it's 2. So anything above a linear and depressed fracture and contusion and subdural hematoma, you really, again, need to keep these patients on your follow-up. And of course, if they were elderly. Morning, sir. Welcome, sir. So for late seizures, the risk factors, as I told you, can be summarized as not only an Enegers study, but in Englander, Kilpatrick, all of them said low GCS, parenchymal blood, multiple contusions, prolonged coma, residual neurological deficits. So many studies have given this. And if you've done an EEG at 1 month prior to discharge, and the EEG beyond 1 month, you say 3 months or 6 months, continued to show focal abnormalities, that was a high risk factor for recurrent seizures. So it will do well in those patients where you want to predict. And you could do an EEG maybe when they come for your follow-up after 3 months after discharge to look for an increased risk. If the patient is alcoholic, again there's an increased risk. There's a family history of seizures, there's an increased risk. There's an ApoE4, sorry, and haptoglobin HP2. This was the genetics which created risk. What kind of seizures can be seen? Be prepared to see any kind of seizures. They could have focal impaired aware seizures, they could have focal aware seizures, they could have non-convulsive status, they could have bizarre manifestations of aphasic seizures, amnesic seizures, they could have generalized tonic-clonic seizures which are secondary, they could have an epileptic myoclonus, and they could have an APC, so the whole spectrum of seizures. Our large study, which was published in the Seizure Journal by Amit Thapa, who is now in Nepal, we studied these patients and we followed them for 2 years. And you can see here that the vulnerable age was the most bountiful age for the nation. So 20 to 50 years was where the maximum number of patients were there. So these are really the people who are doing nation building. So the head injury is involving these patients. And these are the people on follow-up. We had half of them who continued for follow-up after 2 years. So you can see here the seizures, the study was done for post-traumatic epilepsy. So immediate seizures were seen in 6%, late seizures in 3%. And the odds ratio, if they had an associated medical problem, increased the chance of having seizures by 4.3%. And of course, severe head injury. If there was associated behavioral and cognitive issues following the head injury, the chance of seizures was more. And if there was, poor GCS, GOS, then also the chance of seizures was more. As you can see here, those with seizures had higher mortality and dropout. So you can see our patients who have seizures will not survive to a large extent as compared to those who did not have seizures. Now, I was given the topic guidelines. So I've given you a preliminary introduction of the types of seizures you can have. But the guidelines which are there, the latest one is of 2022, published by Rani Lindberg. And she's looked at various studies which I will go through, and the drugs which they've looked at is phenytoin, levetiracetam, valproate, and carbamazepine. Not, the neurologists have almost 20 drugs, so not all the drugs have been looked at. But if you look at the drugs which were looked at her analysis before she gave the recommendation of management of TBI, CBZ was better than placebo for early seizures, but no difference for late seizures. Is that my timer? I don't know what that was. Okay. This is another study which is very well quoted, Temkin. And of course, those who were on phenytoin, 3.6% had seizures up to day 7, whereas 14% had seizures if they were not on phenytoin. But at the end of 1 year, and after stopping the phenytoin, at the end of 2 years, there was no difference in late epilepsy. Valproate was ineffective, so please don't use valproate so randomly. Glucocorticoid use did not reduce the occurrence of seizures, and remission rates, in long-term late seizures ranged to up to 40% as compared to 70% in the general population. Levetiracetam, it's a good drug. It's been tried in children, it's been tried in adults, and it's entered systematic reviews. So if you look at levetiracetam systematic reviews, patients who were on levetiracetam had better disability rating scale. That is, they did better. So from Zlafresky's study, it was postulated that levetiracetam also could have a neuroprotective effect in post-head injury seizures. So as of now, levetiracetam seems to be non-inferior to phenytoin and should be used as a standard of care. The other systematic reviews and Cochrane reviews, early seizure anti-epileptic use till 7 days, taper and stop. If there's significant risk in the form of multiple contusions, poor GCS, depressed fractures, then you have to continue it for longer. Phenytoin versus levetiracetam. Levetiracetam is probably not inferior to phenytoin. We tend to not use phenytoin anymore, even for acute status, because of the happening of purple glove syndrome, which could have medico-legal implications. Plus, it produces hypotension, cardiac issues. So prophylactic use is not recommended. You can use it for 7 days in moderate to severe head injury. Try to reduce it after that. The time is over, but I'll conclude by saying that in some patients you will have non-convulsive status, and all the neurosurgery residents must have the status protocol with them, because you cannot be searching for doses. When you have a patient with non-convulsive status in your ICU, the doses should be with you on your mobiles or with you in your mind or your brain. So these doses are sacrosanct. If you underdose your patient, the seizures are not going to be controlled, and you give them midazolam, 5 milligram in children, 10 milligram in adults, IM or IV, whichever route is available to you at that point of time. And then, of course, you can load them with levetiracetam. 60 milligram per kg is the loading dose. So don't load with 20 milligram and say, मैंने 1000 milligram दे दिया, 7 kg का बंदा है. Please do a full loading. If that fails, then try to give, lacosamide if the ECG is normal. And you can give Rice tube medication like perimpanel, topiramate is available to us. And if that fails, of course, midazolam drip with ketamine has to be used. I think my time is up, and I would answer questions rather than go through my slides, as I don't want to delay the session. Thank you.
Thank you, ma'am. Thank you very much. Any questions? I think these are very important inputs from on the neurologist panel. Dr. Mishra, please. Mike.
Real good topic in the care of trauma. I want to see. I want to know that do you recommend the EEG monitoring as a proper protocol in the head trauma patient, or it is a case-to-case basis?
So I had a slide on that actually. So if you have an unconscious patient in the ICU, whatever the cause be, I'm not talking about trauma, about 30% of them will be having non-convulsive seizures, and about 10% of them may be having non-convulsive status. This is just any altered sensorium in the ICU. 50% of these are supposed to be the head injury patients. So head injury, particularly if there's a bleed and a contusion, there's a higher chance of them having non-convulsive seizures, which you cannot make out visibly, or non-convulsive status. Now what is recommended is wherever you find that a patient has an altered sensorium, which is out of proportion to what he should be having. So there is a very mild injury, or the brain is not showing anything really, catastrophic, but the patient is in deep altered sensorium, and this sensorium is fluctuating. So the morning resident is saying the patient was M5, the evening resident is saying M2, next day morning the patient is again M6. So then wherever there is fluctuation and wherever there is unexplained altered sensorium, or your nurse, ICU nurse who's alert, tells you there's a subtle nystagmus, or a subtle twitching of the face, or blinking of the eye, or twitching of the thumb, or the feet twitching, then you should suspect maybe the patient is fluctuating and deep altered sensorium, which is out of proportion to what I as a neurosurgeon expect, may be having status, in which case it is recommended to attach the patient to a continuous EEG. Usually 100% of the seizures are picked up within the first 72 hours of recording. And that's why I keep telling the neurosurgical team that please get more CEG machines. Right now in our main neurosurgery unit, we have one CEG machine, and in the trauma we have one CEG machine. So it is difficult for, keeping up with the number of patients you have. So ideally monitoring these patients with a CEG for at least 72 hours is required. And the CEG machines are superior to the video EEG machines in that they have something known as the trends parameters. So they will tell you just with the graph of the trends, you can see the peaks and the troughs, and you can take your cursor to the peak and make out whether it's a seizure or not. If you can't, you can take the help of the neurologist. Or you can have a trained neuroanesthetist. The neuroanesthetists in our team are trying to familiarize themselves with the CEG. So I think wherever such a situation is there, and you've ruled out a metabolic state which is causing fluctuation, it is warranted to do a CEG.
Thank you.
Thank you. Any other questions, please? Thank you, ma'am. Thank you very much.
Thank you.
Now I request Dr. Vivek Tandon, available? Yes, please go ahead with your topic. Ethical dilemma in neurotrauma. Please, sir. Next.
Good morning, sir. And I would like to speak on a topic which is very near to my heart, and that is ethical dilemmas in treating neurotrauma patients. And I was hoping to see more residents, but since I see less of them, I've modified it a little bit so that I give you and leave you with some food for thought for this whole conference and workshop. So we'll be discussing on-site emergency IPD and how the research reporting is there. And incidentally, yesterday, I was speaking with Marco, who happens to be a judge in Italy. And we were discussing about the laws which are there in the country. So in our country, if you look 20 years back, there was skepticism that if you take a person who has sustained an injury to the hospital, the police will ask you questions. And how many people used to bring these patients to hospitals? Very few. People were not happy to help a person who was in need. And that is how this Good Samaritan law was made in the country. And as a society, I think that we should make the general public aware of this fact, because the scene at the accident site is a very common thing in the country. People will gather around, they will try to help the person, but who is going to take the person to hospital? Very few people will come forward. I think as a society, we should come forward and we should educate people that today we have this law, the police is not going to ask you questions. You bring a patient to hospital, you can even be rewarded for that. There is no problem. And even in countries like Nepal, the laws are even draconian. People will not even help. They may go ahead and kill the person because of a very simple fact that they will have to take care of the person if the person has been injured. I think we should, as a society, bring forward changes in the law as well. Injury prevention, if we look at the history of neurotrauma, what percentage of people have been helped by the new interventions? Hardly any medical interventions have changed the mortality. What has changed is bringing in some preventive measures like helmets, seat belts, and incidentally, Dr. Mishra organized a neurotrauma conference a few years back. He brought in a public program where they were speaking about the public policies that are there. And I read a newspaper article very recently written by a doctor, and he had spoken about the dilemmas that we face as clinicians. We, like Dr. Mishra is a private practitioner, if he preaches that you should have preventive measures that brings down the head injury, I believe that it will bring down his practice. So we should take away that myth from the minds of people, and we as clinicians should teach what is correct. Bring in changes in the law, make it mandatory that people start wearing helmets, bring in use of preventive gear. Now this part is for the residents. I see many times in casualty patients walking in, it's a busy casualty that AIIMS has, and what we see is when we ask why the patient has not been shifted for the operation, the resident will tell you, I'm waiting for the relative to come here and give the consent. Consent in different parts of the world means a different thing altogether. What constitutes as consent in our country is basically a patient who is in conscious state, he can give you consent. At the same time, the relatives can give you consent. And at the same time, in case a person is dying, say for example, because of extradural hematoma, you're not supposed to take consent if the relative is not available, patient is not conscious enough. You can take consent from a fellow doctor, and it's a practice that we follow in our center, that we take consent from the emergency person who is on duty and the person who is treating, and we go ahead and operate. I believe the same should be practiced throughout the country. It will save many lives. And then we make very common mistakes. We do not fill forms properly when we are taking consent. We do not take re-consent if there is a new information which is available. And sometimes we have explained written things in English and a Hindi-speaking person is not able to understand. Date and time, lucid interval, these needs to be factored in. We need to educate staff, have a checklist, follow it religiously. That will prevent many medical legal problems that are there. Spine cases, very, very commonly in our center, we see residents taking consent from the relative. The person who is conscious is an adult, he is supposed to give you the consent, not the wife, not the friend, not relative can give you the consent for surgery in these patients. Now, ethics of dealing with very severely injured patients. These people are superheroes. Christopher Reeves, and who doesn't know this other person? Super drivers. They sustained injury, one person with a head injury, another person with a spine injury, and one died few years back and another is in a practically vegetative state. They have spent millions of dollars and yet they were not saved. How many of us can spend that much amount of money? Probably none amongst us can spend this much amount of money. We need to counsel relatives. We need to tell them honestly that this is what is going to happen. And how do we do that? I think as AIIMS, which is the apex institute of the country, we should bring in a curriculum where we teach students how to counsel the relatives regarding this. We should be honest. Pentaplegic patients, they will occupy the beds. Relatives will remain here in the hospital. The whole family perishes. We need to be very honest, and we should prepare the relatives for the bad news. And these slides are from the WhatsApp group that my family has. People keep on sending these messages. If you make a mistake, it's okay. I mean, you can go back again, and life will give you another second chance. In neurosurgery, life doesn't give you a second chance. Many times. You can make a wrong diagnosis and still get away with it. You can treat a person, cut the internal carotid artery and still get away with it. But believe me, you say that a person is dead and the person was alive, you are finished. That day your career is over. Never make that mistake. Neurotrauma patients are very often kept for brain death and organ donation. Follow the protocols which are there. If you are not following the protocol to the last bit, you are inviting trouble for yourself. Do not make mistake there in pronouncing a person as dead. Believe me, you will end up with a lot of problems. Now, when you are pronouncing people as dead, the law of the country for organ donation is there, and it's a cut copy paste version from the UK law and from the Western countries. Our law defines brain stem death. It's not about brain dead. We are not talking about the electrocerebral silence. We are talking about brain stem death. So, do we require ancillary tests? The answer is no. If there is any confusion, you can order. Otherwise, you don't have to order any ancillary test. Now, coming to what happens if the relative of a patient says, please do not remove the ventilator, what do we do? The law speaks very eloquently about it. Dr. Deepak has said that, we can switch off the ventilator, but the fact according to me is that the law is for organ donation, and at the same time in the country, the body belongs to the relative, not to the state, like it belongs in the NHS in UK, from where we have taken the law. And in UK, the doctor can decide to switch off the ventilator because the body belongs to the state. Here, the body belongs to the relative. Be careful when you are taking this decision to switch off the ventilator. And then I will say that you will always face few dilemmas, like for example, this case, which was a Batla House encounter case. A patient was brought in, wheeled in, many police officers were injured, terrorists were injured, and these people walked in the casualty. And I learned a lesson that day that we must provide unbiased care. One of us was very happy looking after the policeman, another one was running here, there, for getting the blood and everyone. But my senior, who was there in casualty at that point of time, I was in ICU, called me, and when I was running around, he said, you don't think what these people are telling you. They will all stand outside, and I'm telling you, you take care of every person who's here, and don't think anything about it. That is a very important message according to me, and we should look at it, and we should provide unbiased care. Workplace violence, this is AIM slide. Workplace violence has become very, very common these days, and doctors are being harmed by the relatives. It is very important to have a casualty which is well managed, well taken care of, security is there, say no to workplace violence, and this message should be very, very clear to the relatives of the patient as well. A well managed casualty which is not overcrowded will be very safe for the neurosurgeons, and it should be like this. Evidence based or evidence biased. You have ChatGPT which is coming in, you have all the AI algorithms which are coming in. They will continue to guide you to do what is required, but use your judgment, use your rationality. That you should be using when you are treating a patient. All these things are only meant for the guiding tool. And last but not the least, there are many myths which are being propagated, and as a society we should talk about it in these meetings and dispel these myths, whether brain stimulation is going to help, stem cell transplantation, and even the head transplantation. Whether these are going to work or not, people think the person who is not improving at all, they will go to any extent to help their relative. But as a society, we should talk, we should tell that these are research questions that we are trying to answer. These are not treatment modalities that are in vogue. It's very important. Have formal agreements. These are the statements of ethics in neurosurgery. Avoid criticism of colleagues. Very important. Never say that the person who came before me yesterday took a wrong decision. Don't tell this to the relatives. As a team, you have to treat a person, decide what is the best line of treatment, and communicate that only. It is only then the relatives will be at peace. Beneficence, non-maleficence, never ever harm the patient. If you think that your treatment may harm the patient, it's better to back off at that point of time. Just coming to conclusions, inform and educate the citizens about Good Samaritan law. Proper communication with relatives is going to help. Brain death certification must be done very carefully. Dr. Gupta conducted a workshop also, and follow science with rationality. Thank you.
Thank you, Vivek. Thank you. Any comments? Yes, sir.
Just one small comment. I was really impressed with your one important message, that if there is a terrorist and a police, and if the terrorist is wounded, you must treat him like a patient. I think that's what the medical ethics talks about.
Yeah.
Secondly, regarding the withdrawal from the ventilator, its health is a state subject. Only in Kerala you can withdraw the ventilator after brain death certification. In Delhi you cannot and you should not. You should follow the law of your local state because India is very heterogeneous and we have to follow the state law. So ventilator should never be withdrawn even after you confirm the brain death. Never ever.
One thing you should say, there is like AIMS, there are 4 head injury patients, all are severe head injury. See, many times you unknowingly do wrong things. 4 head injury patients, all have contusion, because I think trauma center gets about 30,000 trauma patients per year. Which one to admit? 2 of them, one extradural hematoma, 15, one temporal lobe contusion, 6, 7. Extradural hematoma, 15, large one, and contusion with a large contusion of temporal lobe. 3 patients, every day we face it. 3 patients have casualty, 1 operation theatre, anesthesia not more than 1 OT. 3 people are operation. 1 by 1 operation, 12 hours. I think these are more dilemma. It doesn't, you face this every day. 3 head injury patient casualty, all 3 require operation, anesthesia 1 at a time. What will do?
You have
Ethics work here, it aims.
Thank you.
No, I want to comment.
so that
I can be convinced, 42 years I work here, 42 years. Many of you people work here, every day you see, all of you, Dwarka, Subodh, all of you have seen, 3 patient casualty, 1 anesthesia, no OT, 1 finish.
We are
another
following
one.
a lot of gray
So the
zones in our
question is
ethics.
that
Completely
here,
understood.
you should take a consent from the administrator, legal opinion, because the question is that 1 bed, 3 people, 1 OT, 5 operation waiting. Throughout night you operate without knowing which one to operate, extradural hematoma with 15 or contusion with 6.
Absolutely correct, sir.
For me it is a problem, for me after 40 years.
Absolutely correct. I think, especially with the high volume centers, and still we are doing the big institutes are doing a very good job. Regarding the terrorist thing, there's some good thing out of that also, helping a terrorist. I was the chief resident and I treated a bullet injury to the head, and when I became a faculty, the patient came walking and all that, and later I realized he was the son of the highest brother of the Tyagi gang, and they gave a letter signed by 15 Sarpanch and all that I am protected for life. So, but I never used that. But still, there are some good things that could happen after treating a terrorist actually. So I've never used that.
I think actually what is the problem here, in our entire medical curriculum, we don't have ethics. In British Medical Council and most of the countries, there are ethics a part of medical curriculum. We till today, I was in MCI, chairman of post-graduate committee, I could not succeed by asking them. I was member of ethics committee MCI. At least make ethics a part of medical curriculum. Have 25 marks in 3rd MBBS or final MBBS. We do not talk anything about ethics in MBBS. Suddenly we say practice ethically. You should be taught practice like Susruta. First is Susruta law, Susruta law, Charaka's law, Charaka Samhita's law. Everything I put down the ethics from Vedic Yoga. Ethics is not practiced in India today. It is for last 10,000 years, the ethics is in practice. I always tell, there is Lakshman Rekha. The Lakshman Rekha red line which Lakshman draw, it has different meaning for Sita, different meaning for Ram, different meaning for Lakshman. You analyze Lakshman Rekha, that is ethics. It's a blind people looking at elephant.
Professor
Joyi,
Mahapatra,
please. Joyi, please.
thank you so much. When you invited me to speak at AIMS Bhubaneswar, you asked me to talk about ethics. I still remember. Friends, Dr. Abdul Kalam gave me his copy of a book, Ethics in Medicine by Rinpoche, and I have his underlined book. If, as you suggested, sir, we can have a copy in every department, if you so wish, I'll sponsor it, and we'll make sure that the residents at least know that such a thing is professed by the people we love. Thank you.
Varun wants to make a comment behind.
Thank you, thank you.
Thank you.
Last comment.
Nice talk. Regarding the anesthesia thing, sir, I'll just add to it. It is only one anesthesia team which is there for the whole night. And you have to wait for the gynec cases to get over and probably a cesarean to get over, and then you end up with the DH.
You have all faced every day.
Yeah.
The cesarean is mother's and child's
Yeah.
life. Your extradural hematoma doesn't get clarity, who is dying with casualty. So these are the real dilemma at AIMS casualty. I am not talking of periphery, where nothing is available.
So nature is giving us justice. The baby should be born first, the terrorist comes last.
Which is least talk about the medical curriculum. Nobody talks about ethics, because we all do unethical practice.
Definitely.
So
Thank you, sir. Thank you, sir. As far as our concern is, whoever is the patient, priority must be given to the situation. See, we see the different situation vary from place to place. Everywhere there is problem. You should not talk about the problems only, how to solve there. That's why we are there. We have to decide and we have to do the best for the patient at this scenario, whatever the background of the patient, whatever may be the thing, and you give the respect to the patient and treat him like a patient. Don't think anything about anything, and you can settle other things after finishing attending the patient. That's all. That we have to do afterwards. Thank you. Next. Next I call Dr. Dwarakanath Srinivas. He is going to talk on problems facing tertiary healthcare services.
Thank you.
That is also, you are also going to say.
Yeah.
Yes.
I mean, this was
He'll
actually,
create more content.
a part of it was done for my, as part of the postgraduate diploma in medical law and ethics. And then we went back and started analyzing our data. So I'll just evaluate what all I found out rather. So the first question is, I mean, we sit at big institute, and first question we need to ask is, are we working in ivory towers? Is in-hospital mortality the true indicator of quality of care? In the rush for privatization and super specialization, are we actually forgetting the basics? And where can we improve? I mean, this statistic has been going. India has the dubious distinction of having the highest rate of head injuries in the world. Almost 70% of all TBI is caused by RTA, more than 1 lakh lives lost per year, 1 million suffering from severe head injuries. And unfortunately, 50% of all these head injuries are the vulnerable road users, like the pedestrians and the motorcyclists and the pedal cyclists, who may be innocent bystanders during the trauma itself. And also the fatality rate compared to the West, it makes very depressing reading. It's 25 times higher than in developed countries. 25% of our patients are under the influence of alcohol. In India, 1 out of 6 trauma patients die. And half of those who die from TBI do so in the first 2 hours after injury. And most of this injury is because of the delay in treatment, and these patients do not reach the hospital fast enough. And the other unfortunate point is that most of them are in the productive age group, with most of them being in the 20-42 age, which are the breadwinners for the family. So it's not only a injury to the patient, it's also injury to the entire family. So this was our data from NIMHANS. And if you can see that the cause, do you have a pointer? Okay. So the cause of injury, if you see, RTA was around 71% of all the trauma. I mean, because of the bias of how the patients come, you can see that lots of our patients were either unskilled or semi-skilled. And here, this is the crux. The age group maximum around 40 to 45% are between this 20 to 50 years age group. And the income again, because again this is the bias of what patients come to a government institute. But this is even more telling. 86% of the patients who underwent trauma were not wearing helmets. 22% were under the influence of alcohol. 52% were moderate to severe head injuries, and 88% two-wheelers were involved. And what are the outcomes? 20% mortality, 25% poor gauze, and 49% moderate gauze. That means almost 75% were either dead or had very bad outcomes. So when we analyzed the pre-hospital care, where we took the, what did we find? I mean, unlike what Vivek said, the first responder was actually the public or the relative or the friend. Police and self were hardly there. I mean, of course, self, only the patient was conscious, but this was a very good sign where the public actually took care of the patient. The mode of transport, again, only 1/3 reached the hospital in ambulance. Most of them came either in hired vehicles or in private vehicles. And the time of admission of event in NIMHANS, again, if you see, most of the patients reached more than 2 hours after the injury. So that means the golden hour had already passed. So where are we going wrong? As you see, the statistics are dismal. The late response, hardly any patient reached in the golden hour. But what was important was it was very heartening to see the response of the passers-by, and this should be encouraged. And probably the Good Samaritan law is actually a very good step for this. Also, the delay in reaching the hospital also says that the lack of infrastructure, especially in the peripheries, both in hospital and manpower, it's particularly acute in rural India and poorer states. The southern states, which comprise 20% of the country's population, have 45% of the country's medical seats, while it is exactly the opposite in the north and the eastern states. And the most important is the cost of treatment. So when you analyze what is going wrong with the healthcare in India, you see there are 5 A's, what we call the awareness, or rather the lack of awareness regarding the healthcare, lack of access, absence or lack of qualified healthcare workers. If you see that even though it has been improving, right now it's 1 per 26,000 Indians, while US has around 1 in 17,000 Americans. And to reach the WHO recommended standard of 1 doctor per 1,000 people, India would have to establish 100 medical colleges every year for the next 5 years to achieve this target by 2030. So and also when you analyze the disparity between the geographical areas and in between urban and rural, you see the working conditions in rural areas suffer from poor infrastructure, both medical and social. Security concerns are serious, especially for women. Financial stagnation and pay disparity between the private and the government sectors are huge and needs to be addressed before you actually make a tangible effort in improving the healthcare in rural centers. So when you analyze what's the difference between the private and the public healthcare, the public healthcare offers healthcare at low or no cost. But apart from a few central institutions, this is very important, it is perceived as unreliable, of indifferent quality, and is generally not the first choice. And private healthcare, even in spite of the cost, there is a preference towards private healthcare, especially in urban and semi-urban areas. But the flip side is that almost 75% of a healthcare expenditure comes from within the households because they do not have any social security. And this unanticipated and exorbitant health costs is actually an important cause of impoverishment. And also there is lack of regulation in the private sector and consequent variation in the quality and costs. Fourth is the accountability, which Vivek touched on, is the incidence of increasing violence on doctors, which actually may make a lot of people actually give up medicine. So if you look at the major heads of which out-of-pocket expenditure was made, medicines hospital actually made around 75% of your out-of-pocket expenditure. The health spending has actually increased from 1995 to 2014 as a percentage of your costs. And this is what I mentioned, even though the public hospitals actually have less than 1/8 of the entire budget for the private hospitals, still a lot of people prefer going to private hospitals. So why is public funded infrastructure important? So, chronic underinvestment in public healthcare has pushed people to private hospitals. There's nothing wrong with it. But states with investment in public health had a higher percentage of people getting treated in public health system. The demand for government hospitals actually increases when the course of treatment requires hospitalization or chronic health care, mostly due to affordability issues. Hospitalization costs in private sector are 5 to 10 times more in the government hospitals, forcing people to borrow from family and friends and probably liquidate their assets to actually take treatment. People undergoing treatment in private hospitals pay 2 to 5 times more for medicines and diagnostics. And what is important is that 1% standard deviation in the perceived quality of public health care actually leads to a 20% drop in the costs of private hospitalization. So it implies that high quality public hospitals put competitive pressure on private hospitals to maintain care standards while reducing prices. Another thing, even if you're insured, privately insured patients pay 26% more per private hospitalization and 27 more out-of-pocket expenses for private hospitalization than uninsured patients in government hospital. So the cost of difference is significantly more between the government and private hospitals. So what are the tangible outcomes? How does improving public healthcare help costs? One is, if you increase the competitiveness of public hospitals, it leads to a decrease in the costs, even in private hospitals, because if you perceive the quality of outcomes, then they become more equal. So people would prefer public health care. You need stricter measures to control violence. Otherwise, the entire health force is going to get demoralized. Could you control the cost of treatment? I mean, you could either have an administered prices like what we do in government hospitals, but both have their pros and cons, either administered prices or market determined prices. The important thing is to improve the standard of care. You need to have peer chosen doctors. And the funny part is 1/3 of all the doctors who claim to be allopathic doctors actually have a secondary high school education. Private sector doctors are perceived to be more competitive and patient-friendly than the public sector doctors, just last two slides. But on the flip side is that the pay-per-income patient model and hospital-driven targets can lead to an increasing number of medically unnecessary procedures. So, opening of more high-performance public hospitals, incentives and ethics, improve health research, boost accountability of healthcare providers, use of low-cost evidence-based interventions to improve quality of care, improve medical ethics education, and expanding the social insurance scheme. The PMJ and the Ayushman Bharat is a huge boon, but of course it suffers from lack of wide acceptability because of the costs involved. So I would like to conclude by saying that the unavailability of beds, the incidence of catastrophic health expenditure, and the lack of experienced healthcare workers has created a perfect storm in pre-hospital care and tertiary care in the country. We need to improve the pre-hospital care, improve the response system, develop skilled manpower, and develop infrastructure with focus on high-quality public health care, and also address the cost of treatment and rehabilitation. Thank you.
Thank you, thank you. Thank you. Any questions, comments?
Very nice, thank you. I stand before you humbly, sir, to say, yes, you compared the West to what you have. But having been in the West medicine for 40+ years, we're not doing as well in many areas. You've learned some of the good things, but you've also shielded yourself from the tremendous waste that we have. Our healthcare dollars are spent by the billions and billions uselessly. Very few patients are benefiting. Respect to Wilco and other people here from the West. We come here not only to show you what we can do, but we come here to learn, because you've shown us efficiency, good quality, and most importantly, a way of handling things that I can take back home and show people. There's so many things I've learned from Uganda and Ukraine and India and other places. Thank you, and stand tall saying you've done a good job with what you have. Thanks.
There's a paper published last year, They have compared the cost at AIIMS and Harvard Medical School. And then they compared that the amount of money you spend and quality of care you get is either better here or equal to Harvard Medical School. So to say that India doesn't have work, so problem is that our budget was 0.6% 25 years of health budget, which has now gone to 3% health budget. Unless you spend 15 to 20% of budget for health care, you cannot match. Even the Kuwait, Dubai and all Gulf countries spend 25% because they don't spend money on defense. So our lot of budget goes in defense, which is 40 to 45%. So our education, health get all the negative aspects. So unless if you increase the budget from 1.5% to 3%, you will see the improvement. So the budget is very low.
So I think the crux is not comparing the Indian healthcare system to the Western healthcare system. It's like apples and oranges. The entire thing is, how do you improve public health care?
Money.
And also, how do you make the private healthcare take more social responsibility. I think, see, unlike the West where it's predominantly private healthcare and UK where it's predominantly public healthcare, India, I mean, we have a combination of both. So the question is, you need high performance public hospitals. You cannot have government hospitals for the sake of having government hospitals, right? I mean, you need to have very towards the shareholders to show profit over profit and show around 25 to 30% margins, right? So they're not bothered with your social healthcare systems and all. So the question is how to use the existing finances, financial resources you have to make them more socially responsible. I think if somewhere over the others you will meet halfway, and one of the way to put cost pressures on private hospitals is to increase the quality of the public hospitals in the country.
Thank you very much. Now we will move on to the next topic. Purva Mathur, is available?
Dr. Purva.
Yes, madam. Antibiotic stewardship in neurotrauma patients. Please, madam. Please go ahead.
Thank you, chairpersons and the organizers. I'll be dealing briefly about antimicrobial stewardship in neurotrauma patients. So what is stewardship? It is basically careful and responsible management of something entrusted to one's care. When we talk about antimicrobial stewardship, I would say it is one of the three very important pillars. The other two are infection control and medication and patient safety, and we combine them with the AWARE classification, which is the access, watch, and reserve classification of WHO drugs. It helps in optimizing antimicrobial treatment and patient outcome. So consider the study which was done recently in Barcelona, Spain, in which they considered more than 5,000 patients, and they found that when they had an AMSP program, after initiation of this program, the percentage of patients treated with antimicrobial decreased significantly, the daily defined doses and days of therapy of antimicrobial decreased, and the mean cost of treatment reduced. So the conclusion was that the implementation of an AMSP was associated with marked reduction in antimicrobial cost saving, and it can have significant impact on optimizing antimicrobial treatment, especially when we are in the midst of a very, very grave pandemic of antimicrobial resistance. So the ITSA guideline in AMSP says that you should have a core committee on antimicrobial stewardship, which would include an ID physician, a clinical pharmacist, microbiology, IT experts, epidemiology, and infection control practitioner. But the most important person in this team is a pharmacist. So a pharmacist leader is one of the core components of an AMSP team in a hospital. What are the aims of an AMSP program? It is to optimize the use of antibiotics, promote behavior changes in antimicrobial prescription, improve the quality of care of patients, save cost, reduce emergence of AMR, prolong the lifespan of antibiotics, because as soon as the antibiotics come into the market, within a year they become defunct, limit the adverse impact, and build best practices. So it is about basically regulations, supply chain access where it is needed, appropriate antimicrobial use, surveillance of utilization, and of course immunization, which is more so in community setting. So consider this case scenario which happened in Barbados. It was a 600-bedded hospital where an outbreak of Klebsiella pneumoniae happened. There was no AMSP facility or a program in that hospital. And in 2012, they conducted an all-facility point prevalence survey, and they found that a number of these patients are actually colonized with the same strain of Klebsiella pneumoniae, which was carbapenemase resistant, and many of them had infection. And there was significant correlation of this colonization or infection with two antimicrobials, that was piperacillin tazobactam and fluoroquinolones. Subsequent to that, they realized that they had only one nurse functioning as an IPC nurse, and then they initiated an AMSP program. They found that this leadership commitment consisted of building a team of ID physician, pharmacist, microbiologist, and IPC personnel, and they found that this outbreak accounted for 64% of hospital cost of antibiotic treatment. and they actually chose one of the surgical ICUs with the anesthesiologist as the AMS champion, and they found that when they made a target to reduce the antibiotic consumption in 6 to 12 months, with this AMSP team, they could achieve the target much faster. There was a 60% decline in the use of carbapenems and vancomycin. So if you have a program like antimicrobial stewardship, you can really reduce the burden of antimicrobial prescriptions in your hospital. So basically, this program lingers on leadership commitment, accountability and responsibility, action points, reporting and feedback, which is extremely important, monitoring and surveillance, and education and training. So this is how the CDC defines the core components of a stewardship program. You must have a leadership commitment, accountability, a pharmacist-led AMSP, action which includes implementing interventions such as prescription audits and feedbacks or pre-authorization for drugs like colistin or very high generation carbapenems, tracking the antimicrobial use, reporting on how antimicrobials are used in each unit, and educating, especially residents. So this was one of the recent studies in which they compared two hospitals similar in structure, and one had an AMSP team without a dedicated pharmacist, another had a dedicated pharmacist, and they found that the stewardship program with a dedicated ID pharmacist was associated with a greater adherence to recommended practices. Also, stewardship or antimicrobial prescription, I would say, should be based on our antibiogram. So we did a 10-year analysis of our trauma center neurosurgery samples to understand what is the antimicrobial profile, resistance profile in our neurosurgery unit of trauma center. And we analyzed all the samples collected from the neurosurgery ICU as well as ward. So of more than 48,000 samples received, 21%, that is more than 10,000, had significant growth. And the predominant organism in our center are unfortunately gram-negatives, which is different from the West, and they pose a huge problem for antimicrobial resistance. If you see the percentage of organism, Acinetobacter baumannii is the most common, followed by Klebsiella pneumoniae. Staph aureus is lesser of a problem. See this antimicrobial resistance. Most of the Acinetobacter baumannii are carbapenem resistant, so that leaves very little choice for therapy. E. coli, again, very high resistance to third generation cephalosporins. Klebsiella pneumoniae, high resistance to cephalosporins and carbapenems. MRSA rate extremely high if you compare to the West. 72% were MRSA, and we did find candidemia also. Worryingly, we also found two kind of outbreaks of Candida auris. Although we only found 6 patients, but you know that Candida auris can spread like wildfire. It's highly antibiotic resistant, and therefore it's important to have stewardship program. Again, this was one study done at trauma center in which more than 2,500 patients were assessed for post-operative CNS infection, and we found that almost 7% had this infection, and again, Acinetobacter baumannii was the most common organism. This was a study done by a neurointensivist in which they found that they did pediatric neurotrauma patient study over a 12-year, and they again found Acinetobacter baumannii and Klebsiella pneumoniae to be the most common organisms. More important about antimicrobial stewardship is also diagnostic stewardship, because we can't keep telling clinicians about antimicrobial, judicious use of antimicrobials unless we give them the correct report. So paramount importance is to give timely, quick and accurate result, quality assured sensitivity reports, multiplex PCRs directly from samples, which we are starting to do now. They're not very effective, but they are very good in initiating the antibiotics for the first 2 days, and timely communication. Microbiologists can do selective reporting, so they can tell you whether it is a colonizer or it's an infection, and also if 2 drugs are sensitive, they can give you sensitivity of a lower generation drug to save the higher generation drug. Culture-proven infections provide a very good opportunity for stewardship because they are easily identified. If there is suboptimal therapy, then it leads to worse outcomes. So one must have prospective audits and feedbacks, especially for culture positive. So if you have a culture with a sensitivity, it is generally very, very advisable that antibiotics should be tailored to antibiotics prescribed. Antibiotic timeouts, which are like once you get a culture report, you should actually scale down, which is known as antibiotic timeouts, which provides a very good option for judicious antibiotics. And one of the I found that these are the 4 leading questions which as providers you can ask, that does this patient has an infection that will respond to treatment? Have cultures been taken? Have you de-escalated your treatment according to culture report? And how long should the patient receive antibiotics? So these are some of the pharmacy-based intervention, documentation, automated changes, dose adjustment, optimization, avoid duplicate treatment like anaerobic treatment and gram-positive coverage, automatic time-sensitive stop orders, and detection and prevention of AMR. Then there are some nursing-based interventions, because nurses are best placed to understand whether cultures have been taken, so they should optimize cultures. When to switch from IV to oral, because they know when the patient can take oral medicine, and when to prompt timeouts, because nurses often know how long a patient has been receiving IV antibiotics. And then there should be quality improvement measures about monitoring of pre-authorized interventions, trainings, and feedbacks given. So this is my final slide. It's a busy slide, but if you really want to start antimicrobial stewardship in any unit, you must do a checklist. This is a SWOT analysis in which you know where you stand. If you have all these core components of antimicrobial stewardship, I think you are good to go with having a team which can build an antimicrobial stewardship program. Thank you.
Thank you. Thank you. Any questions, comments?
Very nice presentation, and I think we as neurosurgeons should be very concerned about this, because once we have in us, we also have Pseudomonas, then Acinetobacter and Klebsiella. And once this gets into the CNS,
It's very difficult.
it's curtains down.
Yes.
It's curtains down for us.
And we find that patients are really dying due to Acinetobacter because one, it's highly resistant, only colistin, and then colistin does not permeate the blood-brain barrier. So if there is a CNS infection, then it's a very bad prognosis for the patient. We did try, our new surgeons did try intrathecal. It was a mixed response because it's toxic also beyond a point.
Dr. Yogi?
Dr. Mathur, thank you. I learned a few things. In the West, we see gram negatives after we give antibiotics, but did I understand you to say your first
Yes.
diagnosis is all gram
Yes.
negatives here?
Yes.
So out here, we are really not bothered about Staph aureus, because if we have MRSA, we are not bothered. We have vancomycin, we have linezolid, we have ciproimmune, rifampicin. We are really worried about gram negatives, which are actually first. We don't see gram positive so often. It's not that gram positive first and gram negative later. We start with Acinetobacter and Klebsiella, which are extremely resistant.
What about the antifungal?
Antifungal, we have caspofungin resistance, which is around 30%. So even antifungal resistance is very high. Anidulafungin resistance is slightly lesser. Amphotericin is very low. So we still have that option of amphotericin or liposomal amphotericin. But of course, then it's toxic
At what
also.
stage we should try to search the fungal?
I really feel that antifungals should be culture based, but we do find a lot of empiric antifungals being given, which is not.
Dr. Subodh?
The 25% infection is very high. I mean, if you take the previous talks into account, that adds to the health cost too much.
Yes.
It's not only treating the trauma what you are talking of. We are talking of treating the complications
Actually,
thereof.
that is the limitation of her talk.
Yes.
She is talking a high risk patient, those who come in coma, and that the highest risk of one is artificial immunocompression after trauma. Second, they are unconscious state. They also have aspiration pneumonia. They remain unconscious. So if you extrapolate that data to routine neurosurgery operation, brain tumor and spine.
No, we are talking of trauma. We are talking of trauma only.
Trauma, what trauma?
The
Trauma with Glasgow coma scale, our trauma center never admit less than 8. Routine trauma will not get admitted unless you are talking about brachial plexus injury, routine operation.
I am just telling that this adds to the
You are
cost of
right.
it.
This is not the cross section of head in neurosurgery profile. It is a trauma center database where patients are in ICU coma.
But this is the general profile.
So you
Most
cannot
North
take
Indian
this as
hospitals,
a standard of care.
Yeah, and it's. Yeah, and
No, that all depends.
I think most of the high volume centers will have these figures.
No, AMR is generally higher in India.
The figure is that what I'm just trying to tell, these are high risk patients, and my study and the study with Dr. Banerjee and me 40 years, the best answer, those who, least infection, those who did not have pre-operative antibiotics and post-operative antibiotics. So antibiotics is not required for routine neurosurgery. You can only give one dose during operation. If the operation more than 6 hours, you give second intravenous dose. If your antibiotic level in the blood is very high throughout the operation, it won't happen.
Thank you, sir. Thank you, madam. Thank you very much.
much.
It's a short of time. We are, I request Madam Maria.
10 minutes talk. These are all 10 minutes talk. 8 minutes talk.
I request
People
Madam
are taking 15 minutes.
Maria Sousa.
Important discussions are happening.
No, that is
Madam?
important.
So much of learning is happening.
Next.
Yes, she's
Quick,
coming.
quick.
Thank you.
We are losing time. I think you should all sit in the front, those who could next person to talk.
Thank you, madam.
Slide.
Please.
Put the slide.
Next person, Varnon is sitting here.
So, good morning, respected chairpersons and esteemed audience. First of all, I'd like to thank Dr. Deepak Gupta for giving me the opportunity to share this platform with you. So, I'll be talking about neuroimaging in traumatic brain injury, AI-based imaging trends. So, we all know that AI has pervaded every discipline today practically, and neuroimaging is no exception. So if you look at the clinical applications of AI in neuroimaging, we could broadly divide them into 4 classes. Firstly, detection, such as in the detection of stroke or in the detection of tiny metastases in the brain. Secondly, in prediction, like in the case of stroke, the prediction of the infarct size, or in the case of a neurodegenerative disorder, the prediction of conversion from MCI to Alzheimer's. Thirdly, in the improvement in image quality, such as in the reduction of image noise or in minimizing artifacts. And fourthly, in the improvement in clinical workflow, such as in the reduction of scan times. So I'll just be briefly touching about each of these applications, beginning with the detection of pathology. So radiological interpretation by human observers is subjective, and it's based largely on our own experience and judgment. But AI is a quantitative and an objective tool. Secondly, it has a high throughput. Thirdly, the detection of subtle pathology which may not be apparent to the eye of the radiologist. And fourthly, algorithms are not affected by fatigue or satisfaction of search. So generally, when we are overwhelmed with thousands of images, we might get fatigued and tend to overlook on certain findings. And contrawise, we might have situations in which we see one crucial finding and then we set out to make the report, but there may be another crucial finding on the same image which we might tend to miss. So AI is not affected by these limitations. We all know probably that the most frequently talked about application of AI is in stroke detection, right from the detection of the stroke to the prediction of the time since the time the stroke occurred, as well as the reperfusion based on the CT perfusion scans, and also alerting the concerned physician. And all of this is accomplished within 5 to 6 minutes of the actual imaging investigation. Within 5 to 6 minutes of the image having been acquired, the treating physician, wherever he may be, gets an alert on the mobile that there is a stroke which needs attention. The second application is in image generation and image enhancement. So AI enables an accelerated image acquisition, which is paramount, especially when it comes to MR imaging. And secondly, in the removal of image artifacts, like in this case where you have a restless patient and there are tremendous motion artifacts, or in this case where the patient has a metallic implant leading to beam hardening artifacts. AI also increases the signal to noise ratio. So here we have a typically noisy image. You can see the grainy texture of the image, and AI has specific noise editing algorithms, and you get images of a good diagnostic quality. AI also enables the reduction of risk associated with image acquisition, such as a reduction in the contrast dosage.
We all know that gadolinium could be potentially hazardous, and now we have AI tools which can administer gadolinium to 1/10 of the actual dose and yet produce images of a good diagnostic quality. Similarly, when it comes to CT, which makes use of X-rays, there is always a trade-off between the image quality and the radiation dose on CT. So if you lower the dose, you end up having a noisy image like this. But using AI, you can edit out all this noise and you get an image of a good diagnostic quality. There is something called synthetic image production. Now we all know that in MRI we use a series of sequences, T1, T2, FLAIR, MP-RAGE. It all depends upon what is the clinical question at hand. But each of these sequences takes time and overall contributes to a lengthy investigation. So using AI, what we can do is using just one set of images, like for instance in this case using just the T1 weighted image, you can generate the T2, the proton density, the T2 star weighted, FLAIR images, and a host of other images, thus saving the time and improving the workflow. We also have this concept of resolution on radiological investigations, and when it comes to MR, the higher the Tesla, the better the resolution. We probably know that 70 MR is also entered the clinics of late, and using AI, we can actually produce images of a high resolution from a 3T image, a 3T MRI, which is akin to that which is generated on a 70 MRI setup and in half the scanning time. Again, on MR, there is a trade-off between the time for the acquisition, the number of excitations of the acquisition, and the image quality. So coming to AI in acute traumatic brain injury, so there are three areas where AI plays a critical role. The first is in the reduction of the time to diagnosis. The second is in the detection of hemorrhage, mass effect, ischemia, hydrocephalus, etc. And thirdly, in the development of triage algorithms. And we have a series of different algorithms from different centers. So when it comes to hemorrhage detection, it's not just the detection, but you can also localize the extent of the hemorrhage. There is something called binary segmentation in which the AI tool just detects it and labels it. And that's quite accurate on this series of panel of images. You can see the AI-based segmentation. And this is what compares it to what an expert neuroradiologist would have done. And they are identical. And then we have something called multi-class segmentation, in which AI is able to segment using different colors the different kinds of hemorrhage, whether it be intraparenchymal, subarachnoid, subdural, etc. Of course, everything has its limitations. So we have instances of false negative images wherein you miss out on tiny intraventricular hemorrhages, false positive in this case of encephalomalacia, which was predicted as a subdural hemorrhage, and false negative in the case of calvarial fractures, especially those close to the sutures. So some of the important limitations are missing out on critical findings, and contrawise, normal or questionable findings being flagged as critical, which lengthens the overall readout time by the radiologist. So broadly speaking, there are two approaches which AI uses, the machine learning and the deep learning. Deep learning is in fact a subset of machine learning. So for lack of time, I will not go into the details of that, but suffice it to know that deep learning can handle large amounts of data of a very high complexity, which the machine learning may not be able to do. But at the same time, deep learning requires something which is computationally very advanced hardware, as well as it requires a lot of data to be able to do the learning part and then make the useful and successful predictions. So different methods are in vogue in different parts of the world, and among the machine learning tools, it's the support vector machine, which is the most commonly used. In deep learning for neuroimaging, it's the convolutional neural network, which is the most common. Of course, from a physician's perspective, there are major challenges. The first is in the development of an accurate and a reliable algorithm. Robustness of the data. So every time you're talking about machine or deep learning, you have a training set on which the computational tools learn the set of features which will help them to make predictions, and then you have a validation data set. So many times you're not able to generalize the data obtained from one institution to that which is obtained from another institution, something which is called as overfitting. And then we have automation bias, in which radiologists tend to favor the machine-generated decisions instead of ignoring their own basic acumen. And then the ethical issues because of the massive amounts of patient data wherein patient autonomy and privacy can get threatened. We have emerging approaches called transfer learning, data augmentation, and explainable artificial intelligence, XAI, which helps to address some of these issues. Then we have something called multimodality imaging, which is in vogue today, making use of different tools, whether it be from MRI or PET. Like for instance, in this patient, we used MRI, DTI, resting fMRI, FDG PET to better characterize the lesion and its effects on the patient. But the only problem of using these advanced neuroimaging tools is the extensive amount of pre-processing and post-processing, whether it's structural or a functional MRI. So just a word about what the future holds. We need to have a multicentric data using large data sets. We need to use multimodal data. We need to combine imaging data with clinical, biochemical, and genomic data, what's called as radiogenomics. Development of imaging-based biomarkers for diagnosis, prognostication, and treatment monitoring, and of course, ultimately, how useful it is on the patient outcome, not merely based on its performance metrics. So, just to conclude, AI does hold the key to translate the advanced imaging tools from the research realm into the clinical arena. And the three areas we need to work on is to decrease the time, the complexity, and to individualize it on a per patient basis. And just to conclude, I would like to remind us all here that AI as a tool is just meant to augment, not to replace the physician's judgment, and it is critical to integrate it into clinical practice without harming clinical expertise. Thank you.
Thank you. Thank you. Thank you, madam. Any comments?
I think I have a comment. First time AI was discussed in 1948, and it was 1952 when a person talked about AI, 1952. So if you think AI is the last word in the world, it's not. It can never, never, ever replace human intelligence. The question is that if AI does a mistake, is it ethical or unethical? If AI does a mistake, is it ethical or unethical? Can you punish the AI, the man using AI? It's a computer gimmicks. When I read about AI, it is 1952. Somebody talk on AI. If it was 1948, right? Yes.
Thank you.
So anyway,
Thank you, ma'am.
It is a future. Lot of complicated problems where the surgeon is confused can be used, but it will probably not be general practice for every patient.
Maybe after 15 years, 50 years, robots will be with AI will be doing hereditary treatment. We will not be required.
We don't know what the future holds, but as in today, it's an
adjunct.
adjunct.
Things are changing very
Yes,
fast.
certainly.
Things are changing very fast.
Yes.
And as we talk about radiology, I think X-ray chests and CT scans, the radiological interpretation would be completely unnecessary. Maybe another 10 years' time.
At least as in today, that's not the case, sir, because AI does make
Today's
mistakes.
screening, ma'am. I'm talking
Yes,
about
sir.
another couple of decades.
So I think time will tell, sir, because no two patients are alike, and somehow you
Ma'am,
need
no
to
one
have-
knew 2 decades ago that this phone would exist.
Very true, sir. And we'll have to wait for 10 years to
Yeah,
see what
10
happens
years.
actually.
Thank you. Thank you. Thank
Thank
you.
you.
Next, I request Dr. Madam.
Thank you.
Madam,
Very
please.
interesting talk.
Please.
Time of
No, yes.
and those of gadolinium. That is, these two are current benefits.
He-
Yeah.
Definitely that
Dr. Venam is going to talk about optic nerve injuries.
Thank
Please,
you.
sir.
Thank you, chairpersons, and I'd like to thank Professor Gupta for inviting me here. My presentation is not seen yet.
It's
Yeah.
seen.
What I'll talk to you all is about optic nerve injuries, and Professor Mahapatra is here.
He is a champion of this and he has published his article. The reason I'm talking to you all, this is the institution where I work, the reason I'm talking to you all is that more of these injuries are going towards the ENT surgeons, and we are going to be left behind because they are very aggressive, and and they are going to be talking also on it, and they are very aggressive in it, and we'll talk about the neurosurgeon's perspective. They're not very common injuries, and when they occur, they are devastating. Vision is not going to improve whatever you do, whatever you try. And many times we would always tell the patient that if you will try this and your vision might not improve, or it might be the same. They form around 5 to 7% of the incidents in our country, and the road traffic accidents being very common. And the most important thing is that they do not present early, because if the patient is comatose, if the patient is having altered sensorium, it becomes very difficult to evaluate an optic nerve injury. So just to tell you, the optic nerve is a different nerve compared to the other nerves. It is an extension from the brain. So you'll have all these sheets coming just to see the anatomy. You'll have the venous anatomy outside, subpial, and you'll have the arterioles which lie inside around the axons. So this makes it a bit complex, and the problem is that there are three main parts. The parts which are in the orbit is more resilient to trauma, and the part which is intracranial is more resilient. But however, the part around the optic foramen and the optic strut, that's the area where the vascular supply goes, and that's the area which is precarious, and this is when this gets damaged, it is almost like a permanent damage to the optic nerve. So what are the types of neuropathies? They are direct, which can be due to direct trauma, where there is a damage and cut to the nerve, and the indirect ones where there are shearing forces which lead to vascular compromise, and here the nerve is intact, and many times even severe brain edema can present with damage to the optic nerve at a later stage. So pathogenesis, we see there injury produces edema, and edema produces ischemic changes. So this is the cycle we are dealing with, and however we try to use steroids just like spinal cord injuries, but we really don't know what is the value of those steroids. So what we should be looking at is to decrease the time period between this primary damage and secondary damage. We have a small window here where we can, do something and at least try to do something and save that vision. And it's a very small period, if you see this graph, it's a very small window we have. So treatment of traumatic optic neuropathy is basically medical management if you don't see any compression, and if you see an obvious compression, you go in and do an optic nerve decompression. However, I prefer the surgical decompression rather than the endoscopic. And it's not new. This was started in the 18th centuries, then it was popularized by Sewell, and then now it has gained more popularity with the endoscopic minimally invasive techniques. So the main basic techniques are you do an official normal craniotomy or a supraorbital craniotomy, and you can decompress the optic nerve beautifully, or you can go endoscopic and you can do it transphenoidal, transethmoidal. So this is a case. I'll just show you some case illustrations and some surprises also. This was a young male who came with the following trauma, two-wheeler, and then on the later time he found that his vision was going down, and they did a VEP and did the ophthalm examination. Most of these patients come to us later through the ophthalmology OPD, and we found out that there were some fractures here which were going down to the orbital roof as well as to the optic foramen. We did the MRI, and what we decided is to go in for a decompression. So this is a classical pterional, a small craniotomy. You don't need a big craniotomy. And if you see here, we go intradural first to relieve the pressure of the CSF on the nerve. So even just doing this, opening the arachnoid around the nerve can help relieve the pressure. So that's what we are doing. And then one can go extradurally because you can track the optic foramen as well as the canal after seeing it intradurally. So you can drill this optic canal, and one can do a drilling superiorly, medially, and also laterally. You can remove the clinoid also if required. So we normally do it right and left when we do aneurysms. So should not, and that's the bony fragment coming out medially. So this is sort of an extradural clinoidectomy which can be done. Of course, it has to be done with the microscope. And then we have to open this sheet which is covering the optic canal, the dural ring. So once that, if you see the nerve, it is pretty swollen. So one can decompress it in this way and use a little bit of fat and glue to prevent a CSF leak. We always use a lumbar drain for 72 hours. That also decreases the pressure on the nerve. So that was the post-op CT scan, and the patient showed some improvement. However, the VEPs are not very convincing, but subjectively the patient said he's feeling better and he could see a little bit in that eye. Of course, not 100% improvement. This is another case, 30-year-old. See, they're all young males, and then they have these problems. Mostly they're bike accidents, and this patient also had a problem on the right side. Again, CT scan showed fractures. And if you see here, there are loose fragments which are lying superiorly. Again, the same technique, a small craniotomy, open the arachnoid around the nerve first to relieve the pressure. So this is a microsurgical technique. You have to, and this fragment here above is a complete loose fragment. So one has to be careful while drilling it. So this fragment is moving. As we are drilling, the whole fragment is moving. So we have to drill it to a thin shell. And one can go all around the nerve to remove this bony compression. Sometimes the compression is superior, lateral, inferior. So the endoscopic view which you get is only towards the medial side. You will get only the medial compression you can relieve. Now this is a fragment which has to come out in toto to relieve the compression on the optic nerve. So we are getting that out. Now we are going medially as well as laterally, almost 360 degrees, and this is the fragment coming out. So, and that's the optic nerve if you see. It doesn't look too good. However, the decompression was good. Now we're going medially and removing that bone which was lying inferomedial. So this is slightly difficult when you're doing it endoscopically. And then again the same technique, fat and plugging with fibrin glue. And that's the post-op. The patient showed mild improvement. Again, no 100%, and we were not expecting 100% improvement in the patient, but definitely he was saying that it was much better. So this is another one, 18-year-old male. Due to want of time, I will not go to the same thing what we did, and same technique. However, this patient did not show any improvement. Well, I'll just show you some atypical cases. This was an 18-year-old male, same problem, vision loss, and then we said that there's some compression here. If you see on the right side, there was an RAPD. This patient had this fracture. We did a good decompression. One of the patients who immediately after he came out of the surgery, he said, I can see everything with that eye. And we were so happy, and we said, this is like a miracle. Same decompression done. And after 2 days, he deteriorated. He said, now I can't see anything. After 48 hours, he just said, no, everything is black. And immediate post-op, he had beautiful recovery. So you have to be careful. Same technique we did. And then we did an MRI. This was the post-op. And then we did an MRI. They said, no, there is some leak of something close to the ICA. And this was the DSA. It showed an aneurysm, a pseudo-aneurysm in the ophthalmic. So he had to undergo an FD. And he was showing now progressive improvement, but it has stopped. The improvement has stopped now. So he can just see hand movements with that eye. This is another patient referred to us from ophthalmology for optic nerve decompression. So we prepared everything, and on the morning, just before the surgery, he developed some bleeding from his nose. And he was to be taken up for surgery. So we said, wait, hold on, bleeding from the nose, get a DSA done. And this was the DSA. So we have to be careful. Optic nerve injuries will come with a caveat. They will come with this type of injuries to the ICA also. So we have to be careful. Endoscopic technique is good, and the ENT guys are experts in that. And however, it is good for only medial side. It is not good for the lateral and superior part. So this is how they do it, and they can do a good decompression endoscopically. And to discuss, basically, let me go to this reference. This is an EPIC reference. Professor Mahapatra is here, and nothing has changed, sir, since this reference. It is still the same, okay? And it still stands the test. These are my references. To conclude, they are devastating injuries, but I think we have to give the chance of surgical decompression to them. Thank you.
Thank you. Since we have one more of this paper, we will discuss afterwards. Thank you, sir. I request Professor Alok. He is going to talk about traumatic optic nerve injuries, surgical approach. Please, sir.
Thank you. So I was asked to talk about the surgical approach from the perspective of our otolaryngologists. And thank you, Dr. Weller, for putting up our paper on this, which was published 2003. So just to say that optic nerve decompression has been very much part and parcel of this department of otolaryngology. When I joined the department in '88, my postgrad thesis was on this topic, and he was one of the guides. That was a long while ago. That was a time when we used to do these with the external ethmoidectomy approach, and that was a good approach wherein we would sort of find the space between the orbital periosteum and the orbital wall medially, and going through buzz the anterior ethmoidal artery, follow the anterior ethmoidal artery back, and sort of then to the posterior ethmoidal artery, and that would lead us back to the optic canal. And there was this mnemonic of 24 millimeters to the anterior ethmoidal, another 12 to the posterior ethmoidal, another 6 to the optic canal. That changed a fair bit when the endoscope came on, and that was about 2000 that we made our shift from the external ethmoidectomy to the endoscopic approach. This, to my mind, is much simpler, which is why you see so many ENT surgeons getting involved with this now, because we have a lot more landmarks when we come from the endoscopic technique. The sphenoid, which was a very difficult and dangerous area for otolaryngology in the 80s and 90s, is now very accessible to most surgeons. You can find the optic canal laterally. You can often decompress far more than 90 degrees. You can do more than 180 also, depending on the configuration of the canal, and that is it. So if you look at the two approaches, from our point of view, I now prefer the endoscopic approach if feasible, primarily because you get a little bit better angle. When you work on the external ethmoidectomy approach, you're really sort of working parallel to the nerve. It becomes difficult, but when you work endoscopically, you get a little bit better angle to work on it. How do we do it? Of course, the CT scan to try and see as to whether or not how the sphenoid is pneumatized and what is the relation of the optic canal to the sphenoid. It's usually classically at the angle of the superior and lateral walls, but it may be a little bit lower depending on pneumatization. So that is it. This is a very short video, again fairly old. You can see the optic canal on this lateral wall of the sphenoid, and you can just chip it away, actually, the medial wall of it. Occasionally we would drill, sometimes we may not drill or just chip it away. It is the anterior most part, which we call the optic ring, which is the most thicker, and after that it's a little bit easier to chip through. So anterior to the optic ring is the orbital periosteum. I like to take away the wall of the orbit between the ethmoids and the orbit laterally, and that leads back straight on to the optic canal, and that's the simplest way to find it. So you find the orbital periosteum, and it will lead you, and cone in rather, to the optic canal. As you get to the back of the optic canal, it's going to curve medially. Obviously, you know the optic canal nerves medially. From medially, it's not quite easy to know when the canal ends, but the landmark for us is that when it starts to curve medially, you know that the canal has ended, and you're now in the canalicle, and now you're in the intracranial bit. We like to slit the optic nerve sheath because we believe that adds more efficacy, and I'll come down to that. So because much of the compression in this situation can be because of edema in the nerve rather than compression from outside the nerve, because of the secondary injury that was just talked about. So it is nice to slit the nerve, and we tend to use a disposable number 12 blade for that. And that in essence is the operation. We may drill if needed. That is easily accessible now. It was a bit difficult when we started out, but drills are available now, so you can drill the bone if it's thick. And if you are slitting the optic nerve sheath, as we do, then it's preferable to slit it on the upper part rather than the lower part, because even though the ophthalmic artery is generally, or is almost always situated medial to the optic nerve, there is this odd stat that occasionally it can come, the ophthalmic artery is almost always lateral to the optic nerve, but just in case it's medial, it will be so in the lower part rather than in the upper part, I don't think it's a very significant statistic. When you slit the nerve sheath, you can occasionally get CSF, very occasionally. If you do get CSF from the inside, we can just put in some mucosa on that leak point, and that works well to stop the leak. So my focus on this talk was primarily on the technique, because that was my remit. Just to say that we also occasionally do the external ethmoidectomy approach. This is a patient who's been having the operation for a fibrous dysplasia. I do feel that the external approach is good in situations of distortion. If there is distortion because of anatomy, as happens in fibrous dysplasia, then this is a good approach, because you have one additional landmark, that you have the orbit, and you can just follow the orbit back, which will take you to the nerve again. I like to use image guidance in today's day if I'm doing a fibrous dysplasia, because there can be so much distortion that you don't quite know as to when the canalicular bit is done, and also because of the close relation to the internal carotid artery. So, but most of our trauma patients, we won't be using image guidance. So these are our papers, and what they basically told us, I'll just this is what we have been doing. Dr. Mahapatra has always been an advocate of medical treatment for initial treatment of optic nerve injuries. We have been very much doing the same. We get involved with surgery if there's not inappropriate, if there is not good improvement with medical treatment. And generally, their threshold was that visual acuity should be less than 6/60. As we moved on, we have learned very clearly that PL negative is not a great situation. I do believe myself that a lot of unnecessary optic nerve decompressions are undertaken for patients who are PL negative. If somebody is persistent PL negative, has not improved with medical therapy, really you can't expect very much to improve. Today, if there's PL negative and somebody is more than a week, 10 days out since the injury, I would probably not recommend a decompression at all. Timing of surgery, earlier the better, but of course there are other issues which are more significant. You could be having a significant limb injury with blood loss, you could be having abdominal injury, you could be having head injury. So it's far more important to treat those before you get involved. Meanwhile, you treat the optic nerve injury medically, and we always screen for a pseudoaneurysm, especially in patients who have a fracture. So we get an MR and an MRA for a pseudoaneurysm. So yes, that is what we tend to do. This is what we tend to prognosticate to our patients. As I said, if it's complete visual loss, which is persistent, we would not be advocating surgery. If there is partial visual loss, we would advocate surgery. And this is the prognosis based on our own data. So if somebody has partial visual loss, we say that the chances that you will get improvement following surgery is 80%. And the mean degree of improvement is about 40%. So it can be a range. Someone may improve 90%, someone may not improve at all. But the mean degree of improvement is 40%. And the chances of attaining vision better than 6/18 is 25%. And there is this good prognostic group, patients who have never been PL negative and patients who do not have a fracture. And here the chances of improvement are 95%. Mean improvement is 50%. And chances of attaining useful vision better than 6/18 is 40%. So that is our own data, that is how we prognosticate, and some patients agree and some don't. And we move forward as per the patient's thought. So thank you.
Thank you. Thank you. Can we have the questions of both the speakers?
Sir.
Varun, you can come in front.
Sir, I'm a pediatric neurosurgery, so I don't have much experience with this. Just a humble request. I noticed that ENT teams do not use lumbar drains as often as we neurosurgeons. Is that a appropriate observation?
That is with regard to optic nerve decompression? Yes, sir. Almost never. I've never used it.
Yeah, I use it.
You see the difference? Why is that?
I mean, the optic nerve, frankly, I never get a CSF leak except very occasionally. Obviously, it's a different operation. You come from medially, you slit the optic nerve sheath. I rarely, if ever, get a CSF leak out there. If I do, I can patch it out there. That's itself. We have had one leak in '89, which we reported, and frankly, it's referenced quite a bit because everybody likes to talk about it. But that was the one leak we got, which went into meningitis in '89. We have had a couple of leaks since, which we have patched, not a persistent leak, not a post-op leak, only an intra-op leak.
We have the same experience, so we stopped lumbar drainage. Yeah, so I think it's
So,
There is no role because it's not the rage intraocular pressure which is hampering the vision. It is the microvascular decompression. The optic nerve has a very complex blood supply and which is between 6 millimeter of optic canal, and that microvascular damage during the shearing strain of optic nerve. So the orbit moves during accident and there is an axial rotation of the optic nerve, and that shearing strain damages the optic nerve blood circulation optic canal. Now the question arises, why does the operation improve if there is microvascular thrombosis? There is some part of edema also add, but our study said that even after 3 months decompression has helped. So we do not really understand why the surgery helps some patient. But if I have about 1200 cases, and if a person is blind and PL negative for a month or so, 3 weeks, then no surgery is going to help him. So he has to be partial injury. He should have passed some time because you have given the time for natural recovery. I thought immediate optic decompression and taking credit that he improves, because natural process some people are going to improve 50%. If you do nothing, they are going to improve.
Thank you, sir. Thank you very much. So we are now, my co-chairman is going to present CSF rhinorrhea endoscopic or transcranial. He is going to talk. Suri, please. As is.
Before Suri start, I just want to tell you, many patients came to us after 3 days. I just still in optic nerve before Suri start. Many patients came to us after 3, 4, 5, 7 days. They did not come day of injury. So there was no hurry to operate.
Thank you.
Suri. Yes.
स्लाइड नहीं आया अभी. हाँ, वैसे भी लंबा टॉपिक है, 8-10 मिनट में खत्म नहीं होने का. क्या हो गया? दिखाया हो गया? नहीं आया? So, thank you for the kind invitation. Yeah, I thank Jigish, my fellow for, skull-based fellow for his contribution to this talk. This is a very controversial topic, and I'm not talking about, before I talk about the technique, it's very important to understand that CSF leak can happen in the nose, in the paranasal sinus, in the middle ear, in the secondary to trauma, congenital abnormalities, surgical post-operative, inflammation, and neoplasms. It's very strong association. The more severe the injury, the more there can be more is related to the severity of the injury and the number of skull-based fractures. Most of them heal spontaneously. We have seen around 80-90% of them heal spontaneously. It is important to understand because it can lead to meningitis, brain abscess, tension pneumocephalus. Fractures and skull-base can happen anywhere. We've had anterior fossa, where the dura is firmly adhering to the thin bone of the frontal ethmoid and the sphenoidal bones. The middle fossa, they can cause otorhinorrhea actually. And posterior fossa, this was one of our cases which we did when the trauma center was here. It was 2008, midlife there was a fracture. These are and especially for the anterior fossa, this is either the CSF leaks through the cribriform plate or it leaks actually indirectly through the ethmoid. That is important to understand. And 50% of rhinorrheas happen when penetrating injuries, less common in children, and usually happen within 48 hours of injury, and 60 to 80% heal spontaneously within 1 week. And if they don't heal, it is because of the lack of spontaneous healing, because of large bone defect, torn margins of the dura, which are interspaced with the bone spicules, impaired tissue healing, raised pressure. The time and the leak may be delayed because the blood clot of the brain actually shrinks there, the dura matures, the tear matures, or the bone revascularizes and gives away. And a very late onset, we've seen them even 6 months or 1 year after injury. Age-related shrinkage of the brain, the cerebral dural scar does not provide a good tamponade there, or the growth fractures of the ethmoid, especially when there's a traumatic herniated encephalocele. High pressure leaks are more common in spontaneous leaks. The most of the traumatic are not high pressure actually, unless there is multiple skull-base fractures with hydrocephalus and tension pneumocephalus. That is one entity. Pneumocephalus can be present in 20-30% of patients with CSF rhinorias. Risk of meningitis with ball valve as well as inverted bottle effects. This is the algorithm, and practically it will also be the conclusion of my talk. But what we do: clinical suspicion, examination, suspicion of a CSF rhinoria, analysis of the discharge. If you are not sure, go for beta transferrin and all that. Localization of the defect and the surgical management can be transcranial or endoscopic, depending on some indications. This can be a clear visual inspection of a nasal discharge or a post-nasal drip as seen by the patient. The reservoir sign in which the patient moves ahead and the large volumes of fluid are leaking down the nose. Bedside investigations, the target sign in which there are the circles of blood and CSF that are there, and best done on filter paper or cloth. Lab test, beta-2 transferrin, glucose estimation, and raised chlorine estimation. CT scan, high resolution CT scan is important, especially the coronal cuts, to assess the site of the CSF fistula. CT cysternography, we can give mitrizamide or iopamidol intrathecally, and you can have the active leak. So the bone dehiscence, the appearance of the contrast agent in the paranasal sinus and distortion of the subarachnoid space above that. That are the indirect signs. The MRI, the CSF signal in the paranasal sinus is continuous with the intracranial CSF. So you can give intrathecal gadolinium and do MR cysternography. But all of them will be there when there's active CSF leak. Intrathecal fluorescence actually can help intraoperatively. I used to use it way back, maybe I think 15 years ago, when we were treating all the trauma cases here. Now I hardly use it. I think it is not required. The more, especially after the pituitary endoscopy, you actually become good at the endoscope repair. Management of infection, meningitis is the most serious complication, but there's no role of prophylactic antibiotics. Still debatable. Some people give, some people don't give antibiotics. Initial care is conservative. You need a lumbar drainage only after the leak does not stop after 3 days. Then you need a lumbar drain. Till 3 days, all right. What about the timing for surgery? Early surgery is indicated for penetrating injuries, anterior cranial fossa injuries, fossa surgeries, large intracranial aerosols, herniation of the brain tissue through the nose, widely comminuted or displaced fractures. Delayed surgeries are for failure of the conservative management, recurrent or delayed CSF leak, and recurrent aerosols, meningitis, or abscess. The types of repair: this can be transcranial or endonasal. They have separate indications. Multi-layered repair is important. So you, if that you can use fascial lata, abdominal fat. This is what I use. I don't use any artificial material, but you can use a lot of allograft and xenografts that are available now in the market. Vascularized pedicle flap can be used in both the pericranium as well as the Haddad flap from the nose. Either can be used. Coming to the transcranial repair, when is that important? If the leak is to the frontal sinus, extending backwards to the frontoethmoidal region, large or multiple defects in the anterior cranial fossa floor, failed endoscopic repair, associated injuries of the frontal bone, intracranial tumors, lesions are there. The drawbacks is higher complications, recurrence rate, and if you're doing an extra transcranial repair, 100% your olfaction will go. Longer ICU and hospital care. Couple of cases, illustrations. Fracture of the frontal sinus. There's a shattered frontal sinus, and you can see that there's the leak which is coming down the frontal ostium down, and there's a contusion. The best approach would be a transcranial approach. This will not actually work well with the endonasal approach. Multiple fractures of the anterior cranial fossa with a skull defect there, frontal sinus again, and you can see this is a wide defect, and transcranial approach is better. What are techniques of transcranial approach? You can use a microscope, without a microscope, doesn't matter. It can be an intradural technique in which you make a small supraorbital or a pterional or a frontal craniotomy, and these are usually for small defects. Now these we used to do 20 years ago, intradural for small defects. Now we do all of them endonasally actually. For the extradural techniques, when you are, this is important when you have a large defect, multiple skull-base fractures. It's always a 3-layer approach. You do a bifrontal or a frontal craniotomy. You always have a pericranium, a vascularized pericranium. and there's an inlay fascia, an overlay fascia, and a vascularized pericardium. It has to have a 3-layer. Some people actually put an endoscope for the cranial bar hole, and they do an extradural and come back, and I've seen them recurring and actually reoperated them. So it actually doesn't help because you need a vascularized pericardium. If you have a large defect there, you need a vascularized pericardium, and by this you actually don't get that. Endoscopic repair is very good, especially for defects in the cribriform plate, sphenoid sinus, posterior ethmoid sinus, and the anterior skull base, and or a failed transcranial approach. Advantages: a low complication rate, very high success rate, 90% of the first attempt, 98% after the second attempt, shorter recovery time, and a cosmetic preservation. These are the two types of the anterior cranial fossa leaks. One is a straightforward cribriform leak, the cribriform plate is gone and the leak is like that, or a more common ethmoidal leak. It is just lateral to the paramedian, the cristacellae, and it ultimately comes to the ethmoidal layer cells. This is important to note because here you have to remove the ethmoidal layer cells. You have to take off some part of the middle turbinate and actually you have to plug that defect there. There's a 25-year-old male who had an RTA and the essence of the and that there was a left-sided CSF rhinorrhea, more of an ethmoidal leak. So this is a uninostril approach. This is the left side. So the main idea, this was a major deviation of the nasal septum to the left side. So we lateralized the middle turbinate there, not intending initially to remove it, but we did a middle turbinectomy later in this. Then we medialized the septal deviation. We identified there was some CSF leak there, but that is the problem. Many people think this is the leak, and they put some fat there and they glue that. That is not the leak. This is just where the CSF is actually emanating out from, and you have to take off that part of the mucosa because they are all the ethmoidal air cells actually, and you have to go above, take off. I'll show a couple of videos fast. The main idea is all that semi-healed tissue and scar tissue will have a lot of mucosa, scarring, and you actually have to delineate the bone. It's just like putting a puncture. You have to delineate the bone around, you have to delineate the dura, and then you take off the mucosa, and then you actually see the CSF coming out from that. That is the CSF. It's a very small defect there. So you delineate the bone all around that. You have a complete dural edges visible. I always do a 2-layer. Most of the time, it's an inlay between the dura and the bone there. There's a small fascia that can come there, and then an onlay fascia and fat. I can in this video there, and just freshen this bone. Put an inlay fascia. Put another onlay fascia and a fat, and then put some gel foam and just some glue over that. But the problem is, if you do not, I always put a nasal tampon there without any plastic. That helps it to take care for 24 hours. Regarding lumbar drain, I've burned my fingers a couple of times. I always put lumbar drain, especially when I'm doing endonasal repairs. And technique of graft placement, it's always an inlay or an onlay. But what I do most of the time, is a combination of an inlay pericardium, an onlay pericardium, and a fat. So it's always, especially in pituitaries, I've burned my fingers and I put a lumbar. It's no harm putting a lumbar drain for 3 days. In optic vein is different. There's no CSF leak because you can actually preserving the arachnoid. Here it's pouring out. There's another left-sided, a child. We had to do a middle turbinectomy. Because the time is short, I've done a middle turbinectomy, and there's a large defect there. Again, the same principle. Take off the mucosa. See all the edges of the bone. You must see all the edges of the bone before you finish the repair. And then when you've seen the bone, you take off the mucosa from over the dura, and that is the real defect. This is this will heal 100%. That is the part of the dura, that is no dura, there's some part of arachnoid there, and that's all bone. So this will have a combination of inlay, overlay, Maybe they put the inlay there. Antibiotics for 3 days. Always. Starting from the morning of surgery. just, let's see, I think this was a bigger one. And then we go to conclude, yeah. So the overlay fat, the inlay should go between the dura and the bone. The overlay should cover the whole bone and then the fat around it. If you have a much larger one, then a Haddad flap is necessary. But you don't, I never use a Haddad flap unless for these small defects. I think if you need to use a Haddad flap for a CSF rhinorrhea endonasal, it's better to do transcranial. You'll fail. 100% you'll fail. Adjunctive techniques, navigation actually helps. This was, especially for my earlier 10 cases, the first 10 cases, where to exactly go in the navigation helps. The fibrin glue, nasal packing, lumbar spinal drain, and antibiotics. Bone cement, I don't never use. Some people have used them. CSF shunting is a contraindication, risk of pneumocephalus. So this is the final algorithm. If you need surgical treatment for a transcranial approach, the indications we've already mentioned. The main idea is the vascularized pericranium for large defects and non-lay for small defects. Endonasal, you must identify the defect. The problem is if you put your fat on the mucosa or your fascia on the mucosa, it'll 100% fail. And then you say, half of my cases have not succeeded. You have to delineate the bone all around, and you have to put a fascia between the bone and the dura, then a fascia over the bone, and then again fat over that. And it takes 3 days to stick there, so you need I need a lumbar drain and a nasal bag. Thank you. Any questions?
Thank you,
please?
Mitsuri. Any questions? Question from any? Yes.
With regards to the lumbar drain, since we are doing it open, I'm talking about optic nerve, the dural opening is slightly more. So that's why I prefer a lumbar drain.
So for transcranial, I think you're absolutely right.
Yeah.
I'll always, it's like we clip so many clarinodal aneurysms, I know you do a lot of them, and you're opening the sphenoid sinus pretty big, and you're actually exposing the complete arachnoid there. I think it is better to put the lumbar drain, especially when you're doing transcranial.
Yeah, and if a CSF leak occurs, then getting the lumbar puncture becomes very difficult.
It is a dry tap. It's always a dry tap.
I think one thing one must say, in trauma there could be multiple site of leak. So even you do a classical, the leaks which are not seen when the bigger hole is there. Why the classical operation fails, that once you detect one site of leak, we plug that or operate that and another site open up. So you have got seen multiple, what percentage of the cases have multiple sites of leak? Sometimes have paradoxical leak.
One case actually failed, and so right, he had a bilateral. So what I do is, especially in cribiform, I just take off the posterior part of the nasal septum, and I just have a peep on the opposite side as well. Just do a submucosal dissection there and just see the opposite side. But the main idea is not to damage the olfactory nerves there. So bilateral exploration
I have
is.
seen multiple site of leak. 10% as per the theoretical knowledge book writing, 10% of CSF rhino are from multiple leak. There could be paradoxical from the tegment tympani bone. There is tegment tympani rupture and also ethmoid fracture. And you repair the ethmoid and it comes up paradoxical. So in a CSF rhinorrhea, proper investigation. In fact, twice I got gold medal for my CSF rhinorrhea transcranial extradural operation. And that is way back in 94, 95. So the question is that properly investigate to find out if there is multiple site of operation, because you can delay it, but if the second time leaks and you open the same place, you are doing mistake one.
Burning my fingers, I've realized one thing. If you want 100% success in CSF rhinorrhea, do a CT cystoscopy at the time of the leak, and you'll be sure where your leak is. So that's the 100% sure shot success.
Any other question?
Thank
you.
Thank you. Now I call upon
Dr. Raja sir.
Sabhavadi sir. Please sir.
Give him the big hand.
I think you can remember me 40 years back. I was in Stanley Medical College, and there you were working in the hand injury department. Thank you, sir. Sabhavadi sir. Okay, go ahead, sir.
Distinguished chairpersons, I would like to thank friend Dr. Deepak for giving me this opportunity to be here as a plastic surgeon. In the next 10 minutes, I'd like to say what are the different strategies that are available and what do we do now. I think that's all. If somebody should have a facial nerve palsy, I think it's both socially and functionally it's a devastating thing. So what we do is, if somebody has got an acute trauma, I'll just go over various situations. If somebody comes as an acute trauma like this, we refer to as facial palsy, and immediately we open him up, and in the microscope we try to search for the various branches. Say here you see the branches. I think on one side you see the distal side, and then it's in the other side, it's in the flap. So you try to put them back, and it's quite possible to put them back, and research them, and slowly you will find over a period. So you see this eye. Initially it's not, when slowly, they all recover. I think this is one of the best things that could happen to see is, if you see them acute, the best time to repair is the acute stage. I think you need to do it microsurgically. So when they come secondarily or secondary to a neurosurgical procedure, like acoustic neuroma, you have got two problems. I think we divide them into upper face and lower face. Upper face is for, as far as the eye is concerned, there's the upper face. And what do we do now? We have tried a lot of tendon transfers, and now we have come up to the very simplest solution of putting a gold weight. Gold weight, what we have is a very thin film of gold, which is about only a couple of grams, and you place them strategically in their position. So you just open up, and it's also curved, so you really don't find where it is, and you put it behind the tarsal plate, you put it on, you insert the gold weight, and you see how he is able to close the eyes. So they are able to open the eyes, and they'll be able to close the eyes. So he got a good control, and almost they are able to close the eyes. So this is the simplest, and it's very, very dependable. I think that's what we almost win. And second part is the lower face, where we use some dynamic transfers because you need to smile. And there are a lot of non-microsurgical procedures and microsurgical procedures. And non-microsurgical procedures will be where we use the temporalis muscle. The temporalis muscle won't reach because you need to have three phases of insertion. One in the upper lip, one other is in the modiolus, other is in the lower lip. So you could use temporalis itself without any graft by taking the temporalis fascia, reflect it upwards and then backwards with the muscle. And you could divide the fascia into three and then insert them into the upper lip, modiolus, and in the lower lip. And the most important thing is that at repose itself, they look good. I think the most important is they have had a long standing. At repose itself, they look good, and they are able to clench the teeth and do well. You see another lady where we have this. Here you put for a gold weight for the upper face. And you use the facial letter. You just taken off the insertion, divided into three slips, and then attach them. And you will find they are able to do well, and they manage it very effectively. So right now, what do we do? I think right now what we do is microsurgical things. What we do is transfer of the gracilis muscle, and with this blood supply and this attachment to the nerve, the branch of the obturator nerve supplies that. And we take it back to the face and attach it to the nerve, to the masseter. And the whole trick lies in how much of muscle you take and how well you anastomose it, the vessels. And you see, here's a patient whom I showed before. For lack of time, now we'll have each one. I'll give you an example. So that's the way where we start from. And that's the way we open up, and we isolate the nerve to masseter. So that's isolated. And here you find, before we put it, so here we have the three anchoring sutures we put. One is for the upper lip, other is for the angle, other is for the lower thing. We have that, and then we want to find how we put it. And here you have the facial artery, and there the nerve to masseter, and that's the small amount of gracilis muscle we take. And this part of it, we put it off like this, and we anchor it to the zygomatic arch. So that part is isolated. And we divide it into three, and then these three sutures are attached to the three parts of this. So that's how the insertion goes. And you find, see here it works. I think almost it works really well. But you find that we have got now more amount of gracilis. I think initially we put in a little bit of more amount of gracilis that you put, because some amount of it now will get atrophy. And if it doesn't get atrophy, what you can do is give an amount of measured dose of small dose of Botox you could give. So there's the same patient now, so who can get it, and now they learn how to use them. And because it works, I think this is one of the best things that we regularly do. This we also do it for children, congenital anomalies where they have this also we do. See, there's a child with a congenital facial palsy. Here you require the amount of muscle that is taken is only about 12 to 15 grams. I think that's a small amount of muscle that's taken up. The same way isolate this thing and we put it over there, and nerve is repaired to this, and the same way the three switches and here, and that's the repair of the nerve that takes place, and you see they are able to do this. I think that's they all are extremely happy, and it's quite against debatable. As well as the flap, this thing is concerned almost 100% survival with the anastomosis, that part of it. The nerve recovery, I think part of it, 96% is our people where the satisfaction rate. But you could ask, we are using a nerve to miss it, how do they emotionally synchronize? I think that will not be there, because if suddenly you smile, and what is the emotional synchronicity? If you want to emotionally synchronize, that means you need to have it at the opposite now. So what we could have is, if you have acute injuries, so you could use the nerve of the opposite side. I think that's it. So here you find a patient who got this thing, he wanted this type of surgery. I think this is another point we do. So what we do is we take a sural nerve and we pass it from this side to the opposite side. So the nerve grafts go from one side to the opposite side, they go. And in the normal side, we open up and we check for the muscle. So here you find this the nerve twig. So after side, this was the frontal branch, and one branch you see for the lower branch we take. And after these branches, give some branches to the muscles, because you just can't cut them. Other side will go. So you take the distally, you take some branches and repair to them. And you take this, the opposite side, you come them, and similarly you need to attach to this piece. The one problem in this is nobody really wants to have any morbidity on the normal side. So that means you really go distal. So the more distal you go, the amount of nerve, that is the axons, that they are lesser. So naturally the effort will be. If you do not want any morbidity, that means on the success also is lesser. So here you find the partially, most of the times when they used it, they have required, partially they have required, because partially is because we have not used really taken a good amount of nerve. That's what we have taken. So ideally it should give better results, but the result is better when the nerve is proximal. So now what is our present choice is for the upper face, gold weight. It's very dependable, it's straightforward, we get consistently good results. We can really shape it well. For the lower face, I think what we do is free functioning gracilis muscle is our choice. One of the reasons being, if you say the axonal count, if the masseter nerve has got so many axons. Whereas if you have the other nerves, when you take distally, the axonal count becomes lesser. So I think that's the point that we get. So by judiciously using as to how we use it, I'm sure now you are able to get very good results, manageable results. Mostly you are able to make our patients happy. And that will be, so there will end my thought. And thank you so much, Deepak, for this opportunity. Thank you, sir.
Thank you.
Any question from the audience? Any question?
Yogi?
Sorry, sir?
What's the youngest child you can do this for?
So youngest child you can do is, I think wherever you are, how much you are confident of doing the anastomosis. I think what we have done is about 4 years old childs. 4 years is the youngest we have done. But suppose you take replants and all we do in a 6-month child and all we are done. But then we are also a little worried because this is an elective procedure. So the youngest is 4 years we have done.
Yes.
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 What is how do we gauge the weight of the gold implants?
No, it's about, it's only about 3 grams, sir. And it's because we use gold because the relative density is higher, you can make it very thin, because once you put it, you see the eyelid skin is also very thin. If you use stainless steel titanium, it shows up.
But do we need to test it before putting it in?
Why gold? But I don't understand why gold, why not lead, why not...
lead means, sir, it shows up, sir. Lead it
why not has anybody tried double-blind study?
No, sir, because gold, you can make it very thin, sir, because you do not want to, be shown up.
Malleable also.
You do not want to be shown up, sir.
Okay.
This tissue
What, any question? Yes, Dr. Yadav.
Plus 3 grams will be 20,000 now. No? So giving a
A poor man, he will not spend that money.
No, sir, but you are consistently giving good results, sir. I think that's,
Thank you.
Sir, very nice talk, sir. I just wanted to ask one question. When you're counseling the patient before surgery, what kind of timeline you give to them for the recovery?
Sir, for
Because they all expect ki surgery done and, immediately they'll get. So what kind of?
So we tell them 6 months. We tell them 6 months, and we always tell them you will need one more touch-up procedure. Because sometimes the muscle may be a little bit more, and all this tension adjustments. We always tell them, it's a 2-stage procedure.
And of the nerve is damaged 2 parts, vertical part and horizontal part. Multiple sides of injury. Do you see that?
Which one, sir?
In a facial nerve injury, it's common in the vertical part, horizontal part. So when they come in the root, there could be multiple fracture segment. Have you seen that multiple sides of injury?
Yes, multiple sides of injury, sir. We have seen
So they
when
only-
avulsion injuries and all, we have multiple injuries.
multiple-
We take up as distally as possible so that it definitely reaches the muscles.
Thank you, sir. Thank you very much.
I think should comment, final comments.
Final comments?
The final comment is, though the 10 minutes are precious, as Deepak has said, but I think none of the talks have, because they're 2 good talks, they cannot be finished in 10 minutes. But thanks to all the speakers for wonderful lectures and lot of discussions. Thank you very much.
I thank everyone and
thank the grand chairpersons for their wonderful contribution.
Thank you. I thank and I appreciate the AIMS for regularly conducting this thing. Thank you very much.
Thank you very much.